In this video, we'll go over IV induction agents. I'll talk about propofol, ketamine, and etomidate, which are the most commonly used IV induction agents now. Historically, thiopental was used. Now propofol has replaced that as the IV induction agent of choice. So we'll start by talking about propofol, which is the most commonly used IV induction agent. So it works by enhancing transmission through GABA A receptors, and this is a GABA A receptor. So enhances GABA A receptor transmission. GABA is actually the most abundant inhibitory neurotransmitter in your nervous system. So this is going to have effects throughout the CNS. And then for propofol, you're talking especially for the cortical communication, having effects on your level of consciousness. So this GABA A receptor will have a binding site for GABA on it. And when GABA binds, it allows chloride ions, which are negatively charged, to flow through. And this will hyperpolarize a cell, decreasing its membrane potential and usually then lowering the activity of that cell, or making it less likely to depolarize when it receives excitatory signals. Activity. And on these GABA receptors, there will be an allosteric binding site for propofol, or propofol will bind allosterically to enhance the response of this receptor to when it binds GABA. So in the presence of propofol, when GABA binds this, you'll have an enhanced ability for a chloride to flow through this, which will hyperpolarize your cell. This is what a molecule of propofol looks like. It's called 2,6-diisopropylphenol, so you can see these isopropyl groups on your phenol ring. The structure of this is just important because it is not soluble on its own, so it needs to be dissolved in a lipid emulsion in order for it to be administered. So it's that lipid emulsion that makes the propofol white. Let's talk about dosing. Induction dosing for propofol depends on a number of factors, but in general we can say that it ranges from about 1 to 3 milligrams per kilogram. And pretty safely be able to say that this 1 milligram per kilogram dose is better suited for the elderly. And this 3 milligrams per kilogram is best suited for kids, and sort of in between is okay for adults. We'll talk about things that will make you want to adjust these doses, though. Remember, this is what's happening with your plasma concentration of propofol when you give a bolus. So a bolus, let's say this was 2 milligrams per kilogram, the resulting plasma concentration will be somewhere on the order of, 5 to 10 mics per mil. And the target plasma concentration that we're going for is somewhere around this 2 to 5 mics per mil range for unconsciousness. Of course, you'll still be unconscious if you give above this, but that's just excessive. And then under here, we're worried about the patient being conscious. Notice the time frame here. So after about 5 minutes of giving this bolus, this patient is now in the range of being conscious with a mild to moderate level of stimulation. This relates to our duration of action, which then you'd be able to say from this that our duration is about 5 minutes. And then sort of depending on what effect you're looking for, you might be able to say that your duration of action stretches to 10 minutes. So maybe we have a very lightly stimulating procedure, so you would still be unconscious with a plasma concentration that's a little bit lower, sort of out here. So your duration of action really is dependent on the depth of anesthesia that you're looking for. And then you have to think about the time for half distribution to determine really where will your plasma concentration and effect site concentration of the propofol be at any given time. So the time for half distribution is around 2 to 8 minutes. And you can see that it's the distribution of this propofol into different tissues that causes its decrease in plasma concentration, and not the half-life of elimination, which is 4 to 7 hours. So this has nothing to do with how quickly the effects of propofol terminate. Let's say after we give an induction dose of propofol, we want to maintain them in this unconsciousness range. So we'll give a infusion of somewhere around 50 to 200 micrograms per kilogram per minute. I think many people would err on the side of higher doses for these infusions, especially for maintenance of a general anesthetic. Your onset time is going to be very quick, so basically your arm to brain time. So however long it takes for the medication in your vein to get to your brain is how long it will take for onset, because it is very soluble. It crosses the blood-brain barrier very easily, so maybe you're looking at about 45 seconds to 60 seconds. Age will significantly decrease this increase this arm to brain time. So you might be looking for more than even 60 seconds for the elderly. We already talked about the plasma target concentration, but about 2 to 5 micrograms per mil. Common dose adjustments you'll have to make are age. So as someone gets older, they will need less propofol. If someone has shock, like hypovolemic or septic, you'll need much reduced doses, and some sources will even tell you consider using about 20% of what dose you'd usually use for a person if they have a significant state of shock. Obesity often changes our drug dosing, but at least for your induction bolus, it's going to be about the same. Milligrams per kilogram wise for the obese population. Often people will do somewhere between their ideal and their actual body weight for induction dosing. You need to be aware of the hemodynamic effects of propofol, which should not be underestimated. So there's this dose-dependent decrease in blood pressure, and in the wrong patient, this can even precipitate a cardiac arrest. So if someone is hypovolemic or otherwise very sick in a shock state, a regular induction dose of propofol could very easily cause cardiac arrest. This comes from a decrease in the SVR or afterload, and very importantly, a decrease in preload. So the regular venous blood returning to the heart does not do so as effectively. It pools in the extremities, and you will no longer have adequate filling of the heart to get a good cardiac output. Propofol will also act to cause respiratory depression, particularly at induction doses, so decreased resp rate and potentially apnea. Sources will say about a third to a half of people with induction doses of propofol alone will be apneic. And of course, usually you're also giving some type of opioid, so basically anticipate that your patients will have apnea with your propofol after induction. If we are to graph your minute ventilation, so liters per minute of air in and out versus your arterial concentration of CO2, this is your normal curve, where if your pCO2 increases, so does your minute ventilation. After you've given propofol, you still have increase in your minute ventilation for increases in your CO2, but it's not as steep. So there is less increase in your minute ventilation for every unit increase in your arterial CO2 concentration. CNS effects, we've already talked about it being a GABA-A allosteric modulator of receptor activity. It is a central nervous system depressant, obviously, and it causes hypnosis very readily, which is loss of consciousness. It's also an anticonvulsant, so can be used as a rescue medication for status epilepticus, and antiemetic. So a rescue medication for severe post-op nausea vomiting in doses of about 10 to 20 milligrams. You could give this in PACU to try to address post-op nausea vomiting. For the brain, it actually causes decreased cerebral blood flow and decreased cerebral metabolic rate. So what this means is that your brain will receive less arterial blood when propofol is given, but you also decrease your metabolic demands of the brain tissue. So although there's less blood going to the brain, it doesn't actually compromise or cause ischemic issues with the brain tissue. So this is actually good for people who have increased intracranial pressure, because by sending less blood to the brain, you send less volume to the brain and you decrease the metabolic rate of that brain tissue. You may sometimes encounter this paradoxical excitatory phenomenon, which can be a number of things like increased talkativeness or sort of restless agitation. Sometimes people also get hiccups and other spontaneous movements. And usually this excitatory phase is just encountered on your way to an appropriate depth of anesthesia. So if you give a little bit more propofol, sometimes these things will go away. It's important for you to be aware of the complications or things you should be concerned about when giving any medication. So for propofol, we've already talked about this, but blood pressure going down is potentially quite serious. It reliably causes pain on injection, which itself is not a serious side effect, but does happen all the time and is unpleasant for people for that to be the last thing they feel before they go to sleep. And so this happens because of direct activation of your TRPV1 receptors, which are also known as your capsaicin receptors. So this is that hot burning receptor that gets activated by capsaicin. And you can block these by giving lidocaine. So some people will give lidocaine before the propofol or mix the lidocaine with the propofol, something to try to target these receptors and cause less activation. Even a little bit of diluting of the propofol can sometimes help. Because of the lipid emulsion that propofol is in, it supports bacterial growth. Especially if it's open for more than 6 hours. So you have to use propofol within 6 hours of using it. There are additives to propofol now to try to prevent bacterial growth, but this is still a concern, and you don't want to be introducing some bacteria into the intravenous line. Propofol-related infusion syndrome, PRIS, can happen with longer infusions of propofol. So more than 4 milligrams per kilogram per hour for more than 24 hours would be putting you at risk for PRIS. People who are more likely to get this are children, people with high catecholamines. So if you're in the ICU on inotropes, higher risk for this when you're running a propofol infusion. This manifests as a lactic acidosis on your blood gas. You'll get rhabdomyolysis. And as often does occur with rhabdo, renal failure. So this becomes part of your differential for acidosis for people that are running long infusions of propofol. So other than these complications of giving the propofol, it is a very reliable induction medication, and not surprising that it is the most commonly used IV agent now.